Hello and welcome to the Inner Sense channel. Today we are joined by Professor Frank Röhricht, a consultant psychiatrist and body psychotherapist who works some of the time from Queen Mary University of London and has been involved consulting for the NHS since, I believe, the late 80s. He's a medical director for research at East London NHS Foundation Trust. And I approached Frank after sort of finding out about his body-oriented approach to therapy and patient care. And I hope we'll get to talk today about the type of vocabulary and the attitude to dealing with people with medically unexplained symptoms. So please remember to subscribe to the Inner Sense channel for more information about body-oriented approaches and for tips to improve your well-being. Welcome, Frank.
Thank you very much, Ian, for inviting me to this really well-made channel, I have to say. I will spend a little bit of time scrolling through your previous video recordings, and it's really something that adds value to the community in our body-oriented psychological therapy world.
It was the influence of a friend and colleague who was also a body psychotherapist that I think gave me the confidence to move into this type of work, as well as the growing field at the time of interoception research. So perhaps we could start by hearing about the origins of your work. How did, or maybe even before you became a body psychotherapist, for people who haven't come across this type of work, what is body psychotherapy and what are the core principles that still guide the practice today?
Right. I mean, you mentioned wrongly that I was in the NHS since the 80s. That would push me heavily into retirement age. But in the 80s, I came out of high school, and it was quite a decisive moment. I mean, as I said, I listened to other presentations on the channel, and quite similar actually to, for example, what Manos Chakiris and Mark Welch were talking about. At the time, I was essentially trying to pursue some kind of an intellectual career. I was thinking of myself as a writer and thinker, and had a strong interest in philosophy and literature. And so what happened was that, I mean, I was quite politically active at the time. I would sort of respectfully say, well, you can call me a pacifist. And in Germany at the time where I lived, every man had to go to the army, and the only way out was to essentially go in front of a panel, prove your consciousness, and then do an alternative service in social work in particular, or some kind of healthcare setting. And it was only by chance that I ended up being placed in a psychiatric daycare facility or day hospital facility. And I mean, and that was how my life took an entirely different direction because of, I would say, fundamentally two key experiences. So the first day I attended this daycare center, I was waiting for somebody to pick me up there from the staff to introduce me to the service. I was sitting in this waiting room for about half an hour or so, and I could see that a couple of the patients attending that were kind of watching me, essentially observing me quite closely without saying a word. And and after about sort of half an hour, one of these individuals stood up, came very close to me, looked me into the eyes, and said, "Are you scared?" And I was stunned, really. I mean, how somebody could actually know something about me so profoundly, because that's exactly how I felt, really. I felt totally out of place, really. I felt this is a very different space. I mean, the behavior of the people were pretty unusual by any standard. And so I was very touched, really, by that encounter with this particular patient. And so that was a bit of an early eye-opener. And I guess the other major route into body psychotherapy was the very fact that the psychologist leading that unit was at the time undergoing training in body psychotherapy. So I got an opportunity very early in my life to essentially accompany him, to help facilitating these groups, and so I was exposed to a way of engaging with myself and others that was so profoundly different. I learned a lot about myself, which was totally different to all the kind of images that I developed over time on a cognitive level. And at the service itself, it showed me the powerful potential, really, of these interventions and how it accelerated almost therapeutic work with clients, if and when the kind of embodied experiential framework was actually put in place. And yeah, so I made an early decision, really, at the time to not go for philosophy and literature, but instead, I mean, there's probably another important matter to mention here, that the way mental health care is organized is quite relevant, obviously, and there is this, particularly when it comes to severe mental illness management, the power balance really issue around sort of the psychiatrist, the medical person, mostly kind of making the decisions about patient care. And I observed that quite carefully at the time in that unit, because despite the fact that this body psychotherapy psychologist was doing all this amazing work with patients, he was not in a position to put these treatments into place at scale. And so I thought, okay, if I really want to bring this into patient care, I need to go around the houses, really, study medicine first, become a psychiatrist. And so I did, alongside my body psychotherapy trainee at the time.
Wow. So that was for such a young age, that was quite a big commitment to make, to decide to do a complete degree in medicine before then going down the avenue of sort of body psychotherapy. Just to touch on that experience when you said the person came up to you and asked you if you were scared. Looking back now, how would you make sense of what was going on? What do you think that person was picking up on, or what was happening?
So, I mean, there's obviously our profound, rich source of nonverbal communication that this individual was tapping into, sensed my tension, sensed my body posture, I suppose, and inferred really some kind of a mental state by doing so. And I mean, there's something to say about patients with schizophrenia. I mean, that daycare unit was predominantly caring for patients with psychotic disorders, and the basic self in these individuals is often very much disturbed, which leads to all sorts of coping strategies and also pathologies. And I guess that there was less reliance really on what we would normally utilize really to structure our communication in terms of a cognitive planning process of, well, let me think about that individual, let me try to kind of sort of bring previous knowledge of how a situation of this kind might actually feel like. There's much more an immediateness, obviously, in terms of the way sometimes these patients get into encounters. And that causes, on the patient side, obviously, a lot of distress sometimes, because there's almost this constant battle between almost fusion, really, in terms of having no defined boundaries in terms of the determination of the self, and then the fear really of kind of getting into a space with others. And so I suppose there was these two sides of the equation going on. One, an interference on the level of really my non-verbal communication, but also the own internal knowledge of how does fear actually look like in myself, because these psychotic patients are very often driven by profound existential fear, essentially.
Yeah.
So, I mean, that is nowadays described really, obviously, in scientific terms, where we talk about the mirror system, for example. Implicit knowing is a term that's used very often when it comes to almost mimicking really the other, really in observing and kind of sort of playing it through as to how it might feel in my own self if and when I put myself into that position.
Yeah, and you can sort of see how you mentioned about the sense of self is people with schizophrenia may struggle with their sense of self. I guess if they're already always um, role playing the other person, trying to predict what the other person might be feeling like, then they're kind of constantly generating, simulating other people's or what they expect other people might be feeling. Then, yeah, it must be very difficult to maintain or recognize appropriate signals for your own bodily sensations.
Yes, and there's this sort of sensory integration deficit that's been described really for psychosis, and hence also, I mean, a very important therapeutic angle really from the perspective of body psychotherapy in order to help those individuals, because very often a basic sense of self can actually be restored at the level of my own physicality, creating sort of anchor points in my own bodily sensing, and yes, interoception comes into that quite profoundly.
I hope to talk a bit more about the research you've done and some of those approaches in a while. Can we first sort of define a few terms? So for you, what does embodiment mean?
Yeah, well, that's a big topic in cognitive sciences, and it's good that it's such a big topic. Lots of publications deal with the term, and I think my take on it has to do with what's also referred to as by Thomas Fuchs and others as the extended mind. So embodied cognition, extended mind, I think is best understood, particularly for clinicians, in terms of emphasizing how the brain plays an important role as a player, but not as the central agent in regulating aspects of ourself in relation to others and to the world. So the so-called cognitive abilities that we all, I think, to some extent overrate really in terms of to what extent do they drive our behaviors. They're all dependent upon bodily processes, but cannot at the same time be reduced to biology because we have the self-reflective capabilities and in terms of forward planning activities. But it's a rich source of information that needs to be integrated at that level, and it's always for action. I think that's a very important point about embodied cognition. So perception and emotions are for action, and this action orientation almost shapes entirely our cognitive processes and not the other way around. And I mean, my colleague Lambros Malafouris, a philosopher and cognitive archaeologist from Oxford, phrased the term "thinging" rather than thinking, trying to really just symbolize really how what we almost sort of tend to perceive as an offline process is totally enmeshed and embedded in the perception of the outside world, of our interoceptive regulation processes, and so on and so forth. And
So, sorry, what do you mean by an offline process? What kind of offline process?
well, that's the kind of sort of paradigm, obviously, that the embodied cognition paradigm has almost deleted now. The idea that thinking is an offline process that is devoid of any sort of bodily processes, where you can actually sit still and deprive yourself of your sensory sensations, and then have almost a computer-based sort of software-driven kind of engagement with the world, and that's not really happening.
I mean, yeah, so the thinking is always in service of keeping the body alive, or and working out what is best to do next, what action, as you said, to take. So the thinging is the thing that we do next, or the thing which the object which the affordance which we're
That's
aiming
the
for next.
main idea, really, that thinking is always object related, and the object relatedness means perception, and you need extra and interoception in order to obviously get that process in motion. And which is why I think it's a nice term, really, thinking, that to capture that notion in distinction to a traditional representational approach in cognitive sciences.
Mm. So you've done lots of research over the years, and you mentioned that your early clinical work was around, or your experience in the wards was with people with schizophrenia. Can you summarize some of your approaches to research? And I'm aware that you've sort of looked at how body psychotherapy approaches may be useful or not to certain groups of patients. How do you assess that, and how do you capture the usefulness or absence of it?
Yeah. So, I mean, there's two elements of the question. And I guess the first thing to talk about is the question as to how body psychotherapy can be relevant for these severe mental disorders. And I think that's an important starting point, because I think none of our existing therapeutic approaches can claim to be the sufficient answer really to these very complex conditions. So I think we're talking about contributions to multidisciplinary or interdisciplinary care packages. And that also means that at particular junctures, really different interventions are important and necessary and helpful for patients. But I think it's important when we talk about body psychotherapy in the treatment of severe mental illness to take the starting point really from the experiential perspective of the patients. So what do they actually experience? Because the standard approach to psychopathology is a descriptive one. So you label certain symptoms that are observed, and then you bring them together into a cluster really of signs, and that is the basis for a diagnosis. And it doesn't make any reference to what does it mean from a patient perspective. So take the example of schizophrenia. We were talking about a loss or an essential sort of primary deficit in forming almost a coherent bodily self, which leads to all sorts of difficulties. For example, perception that I'm not my own agent, really, in terms of my thinking and acting process, losing boundaries, feeling as if I'm invaded by others who can actually do something to me without me actually wanting that, and so on and so forth. So there's a level of experience really that needs to be needs to take center stage, and then to see really how, from an embodiment perspective, we can actually bring interventions that can help these patients at the level of these fundamental disturbances. So when we talk about a fundamental disturbance of the basic bodily self, we need to obviously help these individuals to create a sense of reality within their own physicality, create anchor points, work with body perception, body awareness, utilize the body to emphasize boundaries, for example. And that can be done at the level of body perception and awareness, but it can also be done in an interactive sense. There's a difference between saying, please don't come any further, or using your hand as a signal and say stop. So and that means for other mental disorders that I explored, for example, in research on the basis of these manuals or body or psychological therapy research these days, always depends on writing up your treatment plan almost in a manualized form, so that it can be explored to research by different groups at different times, so that it's actually generalizable. Yeah, and our manuals take the center stage really around the embodied experience of individuals, devise an intervention strategy, and then the testing, that was the second part of your question, needs to obviously relate to those core levels of disturbance that we are trying to address. So it's pointless to just have a uniform questionnaire around sort of a particular level of psychopathology, if and when the intervention is aiming at something completely different.
Mm.
And that
So if the intervention is aiming at them being able to express their experience, or being able to begin to put boundaries in place and that kind of thing, then some of the maybe the traditional sort of diagnostic measures for schizophrenia may not be that relevant. Is that what you're saying?
Correct, yeah. And that actually, just give you one example from kind of sort of research labs. So we did run a large multi-center trial in the UK on body psychotherapy for schizophrenia based on a previous trial that was almost a proof of concept study. So we saw good effects and we tested it out. And what you do in research when you test complex interventions, you have to actually choose upfront one particular outcome measure. So we were aiming to address what's referred to as negative symptoms in schizophrenia, so social emotional withdrawal, difficulties to express emotions. But the scale that we've chosen was actually not a good match really to the intervention strategy. So we did not see significant results in relation to that primary outcome. Luckily, though, we at the time found a scale that was just about to actually become more popular for the measurement of a particular deficit in schizophrenia, which is an expressive deficit. And a secondary analysis of the trial showed a good effect, really, utilizing that particular instrument. So I think this is the bit of a technical issue in research when it comes to investigating the effects of complex interventions. But it's crucially important to get a good match. And what you have then is a range of secondary measurements. And so we were looking at body images, body perception. We were looking at the way the patients are expressing their satisfaction with their body realities. And those kind of secondary outcomes obviously also matter in terms of further developing the intervention then.
Yeah, I really appreciate that point about the choice of scales and maybe the subtle difference. A colleague from AIU here, Professor Jane Aspel now, she recently became professor, introduced me to the MAIA scale for interoception, the multi-dimensional assessment of interoceptive awareness, which has 6 subscales. And it's really fascinating looking at the questions, and you can soon see that you can't just sort of say someone is good or bad at body awareness. You know, they might score high on one subscale, let's say how they, a sense of feeling like they're in their body, but maybe score low on how they communicate that with other people, or vice versa.
And there's another important matter here, and that is, so improving body awareness, you could argue is a good thing at any moment in time, but it can actually, therapeutically speaking, at an individual level, be quite a difficult and challenging aspect, because we all know really how we operate at the level of really, we don't want to actually feel what's painful, you know? So that means it needs to be embedded in a therapeutic strategy that gives people also an opportunity to do something about it. Because if you just raise body awareness for patients who quite rightly, as part of their coping strategy, try to dissociate really from sensations that are extremely unpleasant, if not hurtful, such as in traumatized individuals. So just improving body awareness could be actually a bad thing, you know. So it needs to be embedded, and this is another obviously tricky issue around the measurement. Really, what's your primary goal in therapy, and that is so individually different, obviously, from patient to patient.
Yeah, it's making me think of some conversations I've had with people over the years working on interoceptive exercises, and maybe we've done a group exercise and done one exercise might be about breathing, and another one might be just about locating where you feel something pleasant in your body. And people, you know, 2 people can have completely different reactions to those exercises. The breathing one may be terrifying for someone has panic attacks, or, you know, asking them to draw their attention towards their breath is, can be really terrifying. So, okay, have you got a sense over the years if there are any kind of diagnostic categories which benefit more from these approaches than others? Are there some that seem to be particularly good for, whereas others it doesn't work so well?
No, I think it follows immediately from what I just said. As long as you devise an intervention strategy that's disorder specific, then you can really take care of A, the level of disturbance from the patient perspective, experientially, and B, try to create a good match between your pool of interventions and the way you construct the manual to the disorder. Then I can't think of any relevant contraindications. I mean, it was for long thought that particularly psychosis is something where you actually stay away of fostering really interoceptive awareness, or in trauma therapy was long perceived as being rather difficult because of the risk of re-traumatization. But even as long as it's embedded into a therapeutic strategy and you know what you're doing at any moment in time, then I can't see any particular preference there. I mean, we in our research, to be honest with you, have taken slightly utilitarian sort of approach of, well, which conditions are not responding well to standard treatments, where do we have an evidence gap, where could we actually contribute something which is meaningful in the world of these very established psychotherapy schools, because that has been a real struggle, really, despite the fact that we now have quite a significant number of RCTs in the field and even some higher levels of systematic reviews and meta-analysis demonstrating the usefulness of these interventions, because the world is so entirely dominated by a cognitive paradigm and the corresponding intervention strategy from CBT, as you know.
Yes, I mean, I feel quite optimistic and hopeful that things are changing slowly.
But there is certainly, on a positive side, a range of disorders which I've been dealing with over the last 10 years a lot. And that's, well, from a German perspective, you would call these disorders, or use the umbrella term, psychosomatic disorders. So any disorder where the body features with somatic symptoms, complaints, distress, without necessarily pointing towards a specific organic pathology. The older term somatoform disorder was still kind of sort of looking for that exclusion criteria, which is why these conditions are also being called medically unexplained syndromes. Nowadays, in the new classification system, this has been dropped. We now talk about bodily distress disorder. But these disorders are really prevalent. I mean, there is all epidemiological studies point towards about 30, if not close to 50% of presentations in primary care coming under that umbrella term. And in secondary care and specialist medical clinics, it's certainly around 50%. And so it's a huge health economy agenda. And there is not really a great deal of effective interventions. And so that's certainly an area of clinical concern where I see a particular place for these body-oriented psychological therapies.
So for that 30 to 40%, would the manuals that have been developed that you talked about, could they be used to explore this group of people, would you say?
Yeah, and we have done that. We've done that in research, and two different versions. I mean, there is obviously a very heterogeneous group of individuals, often presenting to their primary physician, the GP in this country, talking about all sorts of distress symptoms. And that is the fascinating thing here, was that our first trial demonstrated that even 10 sessions of group therapy of a body-oriented nature significantly reduced the symptom burden of these individuals and the corresponding subjective quality of life. We could even demonstrate that it saved the NHS money. Almost every sort of pound invested resulted in a £2 saving down the line, really, because of the changes in individuals' healthcare utilization behaviors, because people with these symptoms are very concerned that something serious is wrong with them, and so they would very often present at different points really across the healthcare landscape.
So if I've understood this right, so people go to their GP or some healthcare provider, and they explain how they feel, their symptoms, their bodily distress symptoms of some form. So it might be a pain in one area, or a feeling of, I don't know, extreme fatigue, or anxiety, something that might sound a little bit like symptoms related to anxiety, let's say, or many others. And currently, the healthcare system doesn't have a way to deal with those if they can't give them a clear diagnosis. So what you've shown is that by bringing some of those people together in a group, and I'm going to take a guess here that they're given the space to express what they feel in a way that feels that they've been heard, that has huge cost savings to the NHS and maybe benefits to the patients as well.
So there are two elements. The one is the being heard, and obviously our language really in the system in terms of how do we respond to that level of distress. So traditionally, for a long time, these patients were actually very quickly put into a particular corner of, well, it's all on the mind. It's all a psychological problem. Let's see how we can get you to see a psychologist, a counselor, a psychotherapist. And that was very often not really creating any beneficial care pathways really for these patients, because they felt entirely misunderstood and rejected at the level of their primary concern. And so a lot can also be achieved by talking differently and an empathic listening that totally accepts the level really of physical distress without inferring really that there is a particular cause. The second element is then the specific treatment that enables these patients to contextualize their symptoms. So that's predominantly what we are doing. I mean, 10 sessions of group therapy is not a high dose really intervention. It's so you can do only so much really, but for quite a significant number of patients, it enabled them to contextualize their distress, and that means to make a connection with what else happens in my life, and that in itself then creates obviously chances to address this on the behavior level. And sometimes it was all at the level of, well, attending to my physical reality in a different way, in a caring, respectful way, learning some techniques really. You mentioned breathing, for example, a very core element of any kind of body-oriented psychological therapy work, because it regulates emotions. So there are a number of things that help, but it starts with a dialogue that takes that kind of mismatch situation out of operation, because these very often feel misunderstood.
Yes, yeah. What's coming to mind for me is someone called Mark Solms. I don't know if you've come across his work, and The Hidden Spring. And it's a slightly different point, but his point is if we're conscious of something, then it's because we feel a certain way about something. So yeah, it's tragic really to think that so many people feel like they're being told, whether it's deliberate or not, feel like they're being told that they're imagining something. Whereas, if they're feeling it, if they're aware of something, then they're certainly feeling it. They're always feeling it. So yeah, that's a nice starting point for a patient to be for them to feel like their feelings matter. And then the second step you mentioned was to contextualize something. So if I've understood you properly, then they begin to notice that they feel a certain way in certain contexts or when things happen.
Yeah.
And then they notice the pattern of when the distress is more likely intensifies or it's more likely to happen. And then the third step is for them to think, okay, when this happens next time, is there something that I can do to help soothe myself?
Certainly, yeah. So for these patients, for example, interoceptive awareness is certainly a very helpful tool, and it takes center stage in also in our intervention strategy. So, and the group context allows you to actually explore that in a relational context, because interoception is not only an inward-facing process. Our interoception is totally dependent upon the relational context, and that very often at a very simplistic level can actually be extremely helpful for patients to realize, yes, I came to this session with a tummy pain. I was really concerned about that. And I started to actually engage with the stomach pain, not at the level of what causes my stomach pain, but how to actually sense it. What happens if I put a hand to my tummy? So what does the warmth do to the pain, you know? What happens if I engage in a playful exercise with somebody else in the group, where we kind of explore our body surfaces really with balls rolled over the surface, just to explore the skin sensations in that respect. And you can then actually work yourself into those kind of observations of, well, the symptom is not static, the symptom is not set in stone, but it depends on the way I relate to my symptom, and it also depends on the way I actually engage with others, and where am I, and what am I doing in this very moment? All of that matters, and
So they begin to build confidence that they can have some influence over what they're feeling.
This goes alongside something which is important in any form of experiential therapy. So body psychotherapy, the arts therapies work very much with that particular aspect, and that is resourcefulness and playfulness, I would say. So the standard approach to psychological therapy has been for decades to concentrate on people's deficits, talk about problems, you know, and an embodied sort of approach enables people to also capitalize really on their capabilities. What works well in my body is as important as the symptom that I'm so concerned about, you know.
Yeah. So contrasting that to, the fear that if I bring my attention to my body in any way, or bring attention to my breathing, then it's going to be a horrible experience. Then maybe finding some way to draw attention to an aspect or a channel, or a channel of feeling. I mean, a kind of area or a layer of sensation that maybe feels okay, or might even feel pleasant.
And there's always an overlay with other difficulties. For example, in all these somatization disorders, we see a huge degree of overlap with anxiety, depressive symptoms, and that can be dealt with alongside. I mean, anxiety is a profoundly physical sensation. You sweat, you get tremor, you get shakings, you feel tense, your heartbeat changes. So all of that can be engaged, obviously, through physical interventions that give you, for example, through grounding exercises, an opportunity to down-regulate really these heightened anxieties, to find secure spaces in relation to others, to exemplify. I mentioned the example of the stop sign, you know, that you can actually physically, in a playful way, create boundaries towards others and say, well, this is as far as you can go, but this is my comfort zone. You please don't overstep it, you know? So that experiential exploration of that fear of being invaded, entirely different to a talking therapy situation where you just talk about it in a sort of imagined form, you know?
Yeah. So yeah, giving the feelings and the sensations credit, and working with them. So if you were to sort of be given an unlimited budget and freedom to do some more research, what is there kind of a thing at the top of your priority that you would do for this work to help gather more evidence of how effective it may or may not be?
So, I mean, we have been lucky enough already to very successfully apply for large grants, and that will hopefully go forward. I'm currently, for example, collaborating with colleagues from the Tavistock Trauma Center. We're exploring a manualised body-oriented psychotherapy approach for individuals who've been very severely traumatized. So in medical terms, have a diagnosis of complex PTSD. So that's a proof of concept study, but where all these embodied elements of the treatment approach play an important role. And that would be fantastic to see really more trials and more groups essentially engaging with the opportunities really from this field. So unfortunately, in the academic world, in terms of psychological therapy, research has been, as I mentioned earlier on, very much dominated in the past by particularly CBT. There's a skewed evidence base now because there's so many trials essentially have been conducted exploring CBT, and there's a paucity of research in my field. So I would hope that more research groups are actually picking this up really as an opportunity. Also at the level of basic sciences. I mean, take interoception and as an example. So there's certainly parameters that could be investigated as process parameters for therapeutic change alongside these questionnaires and patient level reports, you know. So that's what I would hope for. Yeah.
I wonder whether I'm just my mind's going, where's the money at the moment with AI? I wonder if there's some kind of well, I imagine there is some of the big AI players looking at how they can develop therapeutic AI agents who could act as maybe somatic coaches or body-oriented coaches. There may be some funding there.
Yeah, I mean the AI kind of sort of bandwagon, I mean, is another way of kind of sort of almost sort of disembodying our realities, and I'm not sure if that's the main partner in crime here. I'd be more interested in people who are doing basic science really at the level of neurophysiology and neuroresearch. I mean, we are increasingly collaborating with individuals who come from that particular background, who actually the other way around, looking to see an applied version really of what they find in a lab situation, you know. So that to me is really the future, because the body is not only an experiential entity, but the body has also its physiology and biology that can be measured really in scientific terms. And so far, the research has been too much really carried out in isolation, I suppose.
Yeah, I think that there's some really exciting work with Lisa Feldman Barrett's work, for example, where she's bringing together different people like engineers and biologists and neuroscientists to try and kind of develop a shared language or a shared way of understanding.
Yeah, I mean,
the body's role.
Particularly still a major challenge, yeah, because our experiences are obviously very, very difficult to capture anyway. The subjectivity stands, and then you bring in these complicated lab situations. They in itself have a major impact on your subjective experiences, and are not exploring therapeutic environments in a natural sense. So that's a really significant methodological problem. So maybe we need more like ethnographic studies where researchers just embed themselves in therapeutic work. And I mean, the other, you asked about where would I put my money. The other important thing I think is process research. So just moving away from the idea that it's all about effects, really a reduction in symptom scores, really on a particular scale, but then we begin to unpick more. So in the body psychotherapy community, what is it actually that happens when these relevant change moments occur in therapy, these light bulb moments that the therapist and the patient feel likewise, something really changed, something switched here, something, the transformative moments in therapy.
Yes. Yeah, I'm trying to, because then there's the sort of contextual effect in the therapeutic session as well, to try and understand. I'm in conversation with a group of osteopaths from, some of them are actually in Germany, others in Italy, and they've got an interest in they've developed an interest in active inference, the sort of the framework of active inference, and they are trying to sort of, sounds similar to what you're suggesting, trying to understand the therapeutic alliance and what else might be going on other than what they have originally been led to believe through their training as osteopaths.
Yeah. True. I mean, there's the research around nonverbal communication, the kind of gesture interactions. Synchronicity has been identified as one marker for therapeutic success. So yeah, I think that it's a rich source of information that could be utilized for psychotherapy. I mean, in the UK, we've got these talking therapy services, used to be called IOPT, and we know that there was a significant number of patients dropping out after the first couple of sessions. So what tells us at an early phase in therapy that there is a likelihood that this is going to be a good therapeutic alliance, because that's what we know from psychotherapy research. That's the most important factor of efficacy. And I guess that from the way people interact with each other non-verbally, there will be some important cues really that we can pick up at an early stage in terms of, well, this doesn't look good, really. It's not likely to succeed.
So the synchronicity you mentioned, is that similar? Are you referring to that in the sense of rapport and kind of coherence between the therapist and the patient, whether it's breathing or eye contact or mirroring body language? Yes, yeah. You've been very generous with your time. I'm aware we're coming up to the hour. Are there any closing comments or recommendations, and where can people find out more about your work?
Well, contact me. That's always the easiest way to find out about my work. And I've got a homepage with my name. It's easy to find, and you will find most of my publications as downloadable PDFs there. Also, with my trust, East London NHS Foundation Trust, I mean, we have this bodily distress disorder clinic up and running, and I've done so for quite some time. There's some useful information about that on the trust website that people can find, and I think otherwise it's really just all the kind of pieces of the puzzle really being brought into set into motion. I mean, your channel is a good example. I mean, let's create a community of those who are interested in the topic of embodiment and what is in there in terms of therapeutic opportunities. I think still the networking could certainly be improved in terms of, there's so many people now picking this up from various perspectives, but they don't necessarily know of each other or talk to each other.
Yeah, yeah, I agree. There's a somatic practice and chronic pain network who I think I found out about you through, because you gave a talk to maybe at Edge Hill or Liverpool University to one of our members. But it is actually hard to keep these networks together when everyone's so busy trying to keep their own organizations going. Thank you so much. I'll put a link to your website. And can anyone, is the East London NHS Foundation Trust, is that just for people in East London, or can people come with body distress? Can people from outside of London come?
Fortunately not. No, I mean, Yeah, just as highly localized in terms of how you can access services. So we need to wait, obviously, until the evidence base is large enough really to get it into nice recommended treatments really for those approaches.
Okay. So I'll put a link to your website, and thank you once again for your time.
You're very welcome.